Hello, everyone. My name is Borbála Körmendy, and I am an ENT resident at Bajcsy-Zsilinszky Hospital. Here is my project list, and let me start at once with my first project, which is investigating the validity of the Bajcsy staging system for congenital cholesteatoma. Congenital cholesteatoma is a dangerous, destructive disease in the middle ear. In the beginning, it can have 0 to minimal symptoms. Usually it's an incidental finding in young children. So this is why the mean age of diagnosis is 5 years. Although initially it doesn't have severe symptoms, later it can lead to cranial nerve palsy, vertigo, and even infections. We usually stratify this disease using the Bajcsy staging system. And since it is a rare disease, we feel it is really important to have a good staging system to correctly gauge prognosis, plan surgeries, and compare their results on a multi-institutional and international level. So our goal with this project was to assess the usefulness of the Bajcsy staging system for predicting congenital cholesteatoma outcomes. Our clinical question was, does the Bajcsy stage correctly predict the likelihood of residual disease? So our population is patients with congenital cholesteatoma. They can vary largely with age because of these minimal symptoms. We are comparing the stages to each other, and our main outcome is residual disease, which basically means that during surgery, a small amount of cholesteatoma is left over in the middle ear cavity. Obviously, if we are dealing with a larger cholesteatoma or a cholesteatoma in a little bit of a trickier location within the middle ear, this can have a higher likelihood. And our null hypothesis was that Bajcsy stage predicts outcome correctly. During our search and selection process, we ended up with 13 articles that we have included in our systematic review and 7 that we included in our final analysis. This is our forest plot. As you can see, the confidence interval for the proportions of residual disease were really wide, and we had quite low event numbers for residual disease, and our heterogeneity is also super high. So what we can say based on this from a clinical point of view is that unfortunately, based on the currently available data in the literature, we are not able to say whether the Bajcsy staging system, whether there is a significant difference regarding residual cholesteatoma in the stages of the Bajcsy staging system. But does this actually mean that the Bajcsy staging system is not a good staging system? But we feel that that's not the case. In the 13 articles that we have found and that we have included in our systematic review, many of them failed or had a really large risk of bias in our risk of bias analysis, because many of them failed to provide the reason why they had high attrition rates, and also a general method for determining what stage they chose to identify the cholesteatomas as. So the reason we actually felt the need to move forward with this project and seek publication for our manuscript is because we feel that while it's very important to have a good staging system for congenital cholesteatoma, due to the inconsistencies in the reporting, we are not able to say whether it's an actually good staging system. Right now, our manuscript is being formulated for resubmission. It was already under review for several months with a Q1D1 journal. Unfortunately, there it was only accepted for transfer to another one of their journals. So we chose a different journal, and right now we are working on the paperwork to be able to resubmit it. I have a different project with a different staging system, but it is very similar to the Bajcsy staging system, although it is used for a different type of cholesteatoma that originates from the tympanic membrane. Our clinical question was very similar as well, but unfortunately, we were not able to move forward with this project because we failed to receive the individual patient data that we would have needed to conduct a similar analysis to the one that we did for the Bajcsy staging system. So unfortunately, we were forced to pause with this project indefinitely. My third project, is investigating the applicability of fat graft myringoplasty, which is a very inexpensive and easy to learn quick method for patching up perforations in the tympanic membrane using a little fat plug retrieved from the earlobe of the patient. This method has been proven effective for small perforations, but there is no current guideline for using it in a clinical setting. So our goal with this project is to provide information about the applicability of fat graft meningoplasty. It is going to be a multi-center trial. The centers involved are going to be the ENT clinic of Semmelweis University and Bajcsy-Zsilinszky Hospital's Department of Otolaryngology. We just handed in the paperwork to Hungary's Scientific Ethical Committee, so currently we are waiting for their approval to be able to move forward with this project. My fourth project is determining the optimal length of follow-up after cholesteatoma surgery using diffusion weight MRIs. Cholesteatoma has high rates of recidivism, so it is extremely important to follow up these patients. And the most frequently used method nowadays for that is an imaging modality called diffusion weight imaging MRI. We like this method very much because if you look at the picture, when we compare it to high-resolution CT or a normal MRI, you cannot see a cholesteatoma in these pictures. But when you use DVI MRI, the cholesteatoma basically lights up. So it's extremely easy to tell when we have a cholesteatoma residuum larger than 3 millimeters. The reason we are interested in this is because we want to follow up patients for an appropriate amount of time so that we don't miss any new cholesteatoma growth and thus risking meningitis or cranial nerve palsies. But we also do not want to burden the healthcare system with unnecessary MRIs. Our outcomes is cholesteatoma growth, which we defined as direct growth or indirect growth. Direct growth means that patients had 2 MRIs taken at 2 different time points, and we know the exact size of their cholesteatomas in these 2 different time points. And indirect growth means that they had surgery, which means that we are fairly confident that they had a very minimal amount of cholesteatoma left over, and then they had an MRI taken, and we know the size of the cholesteatoma on that MRI. And we would like to define the ideal length of follow-up as the point of time when cholesteatomas usually reach 3 millimeters in size, because that is what we can detect on these DVI MRIs. We have already done our preliminary research. We have quite a few individual patient data, and we hope to move on with our PROSPER registration when we have consulted our statistician. So these are my projects. Thank you very much for your attention, and I am waiting your questions.
Thank you very much. Is there any question?
Regarding your second project that had to be stopped, wasn't it a possibility to retrieve individual patient data from the authors of the articles that you selected?
So we spent like a few months contacting the authors of the articles. We also drafted data sharing agreements with them, but unfortunately, since these are quite large databases and they require quite a lot of work for them to be able to provide us with this data, unfortunately, we were not able to reach an agreement with them, or when we did, they failed to follow up with the data, unfortunately. So we have been waiting for almost a year for this data, but unfortunately, we were not able to move on. So
thank you.
Thank you very much, Bori, for your presentation. In your first project, we could see in the risk of bias assessment that domain 5, so the confounding was read for every single study. What was most commonly the confounding, or was it always the same confounding? What could you experience there?
So we had quite a uniform problem with all of these articles. Unfortunately, none of them failed to provide potential factors for confounding factors for determining stages. And obviously, for example, the type of surgery can be a serious confounding factor, because for cholesteatoma surgery, we have different types of surgery that differ in the amount of the tympanic cavity that you open up. The more aggressive you are with drilling into people's skulls, the less likely it is that cholesteatoma is going to be left over. But when you leave such large space uncovered in people's skull, unfortunately, that can also have its adverse effects. So obviously, for a smaller cholesteatoma, we don't want to go in too hard for people's tympanic cavity, and that's why it would be important for to be mindful of the type of surgery that we're using.
Great, thank you very much. Any other questions so far, the audience? If not, I would have another question regarding the POD6 staging system. So what were the stages mainly categorized in or with? Was it then that category 1 versus 4 is just the size, or the mortality afterward, or severity? What was the categorization based on?
Okay, so we have 4 categories. Category 1 is when you can only see the cholesteatoma behind one quadrant of the tympanic membrane. Like if you look at the tympanic membrane, we divide it up to 4 quadrants. If you see it behind one quadrant, it's stage 1. Seeing it behind 2 quadrants is stage 2. A cholesteatoma that includes the hearing ossicles is stage 3, because it's obviously a little bit more difficult to extract it from around the ossicles. And stage 4, when it extends into the mastoid cavity, which is a spongious bone formation behind your ear.
Okay, great. Thank you very much. So rather like a combination of size and location.
Yes.
Are there any risk factors for cholesteatomas?
For cholesteatomas? Okay, so it depends on what type of cholesteatoma we're talking about. For congenital cholesteatoma, we do not, as far as I understand, we don't really know about any risk factors, but there are other types of cholesteatoma. The retraction pocket cholesteatoma that I showed you with the European-Japanese staging system, one of the risk factors for that is a change in ventilation in the tympanic cavity, which can happen in chronic otitis media.
Thank you. Another question. So basically, a conclusion about the first study was that the reporting, the way how the data are reported, is just wrong. Have you considered writing a position paper, just to introduce the best practice, or how these things should be reported?
Well, the thing is, we had different outcomes as well. We also analyzed hearing outcomes. And for example, for that, we already have a standard of reporting that unfortunately none of the articles used. And we also, basically during this risk of bias analysis, the QUIPS tool, we also have a standard for reporting on retrospective chart reviews. But unfortunately, these are not used. We hoped to highlight these standards with this meta-analysis, because in the discussion section, we talk in length about why we actually need the risk of bias analysis.